Good afternoon. Good afternoon, NIH, and all those who are watching by various means through the NIH video stream and through Facebook, which is also putting this out there for the big world, and we're glad the big world is watching because this is going to be, I think, a very interesting hour. We are fortunate today to have as a remarkable commentator on the state of medicine and healthcare, and somebody with whom many of us have relationships of learning from him because of his wise thinking about delivery of healthcare and how research can help with that, Dr. Atul Gawande. He was born in Brooklyn, New York. Father and mother, both physicians who had emigrated from India. He was then raised in Ohio and had a rather distinguished academic career, which continues to this day, with an undergraduate degree at Stanford, a Rhodes Scholar at Oxford University in philosophy, politics, and economics. Put that all together in a 2-year period, and then off to Harvard Medical School. Subsequent to that, got an MPH at the Harvard School of Public Health, but is trained as a surgeon, a general and endocrine surgeon, which he still provides those services to patients at Brigham and Women's Hospital, particularly in the area of thyroid surgery. He's also a professor at the Harvard T.H. Chan School of Public Health, but he is the Samuel O. Thier Professor of Surgery at Harvard Medical School. But many of you know him, not because he has taken care of you personally, although maybe a few people would have that privilege, but mostly because of his writing. And he has been a significant contributor, both in books and in essays. The books you may be familiar with: Complications, A Surgeon's Notes on an Imperfect Science; Better, A Surgeon's Notes on Performance; very well known, The Checklist Manifesto, How to Get Things Right, in 2009, and most recently, a book on end-of-life matters, Being Mortal, Medicine and What Matters in the End. And that was, by the way, turned into an Emmy Award-winning, or nominated anyway, frontline documentary. He's also been a MacArthur Fellow. But I think many of us know him best from his essays in The New Yorker, where he continues to be on the staff. And many of you who we invited to submit questions in advance of his arrival here specifically commented on some of those essays, so in the Q&A we may very well come up with some of those questions and ask him to reflect on some of the things that he has written about. So the way we're going to handle this is Atul thought it would be nice to have a conversation instead of a lecture, and I'm happy to try to manage that and play Oprah. And we're going to have a series of questions that I have myself, but a number that I have culled from the ones submitted by all of you. And then we are hooked up live to receive questions from Twitter and from Facebook. And there's a screen down here that will tell me what those are, and we will pick out the ones that seem most appropriate to get the most out of this hour and see where it takes us. So this is not what you call heavily scripted, but that's the way we like to do things. We are NIH after all. So please would you join me, everybody, in welcoming to the stage Dr. Atul Gawande. Well, Atul, it's just a total privilege to have you here as our guest. You and I had an opportunity to have a somewhat similar conversation back in January at the World Economic Forum in Davos, and a number of issues came up then that might come up again. But maybe to start off, I think this audience would be particularly interested in how you traveled the path of someone who was a Rhodes Scholar, then went to medical school, became a surgeon, but also became such a powerful writer and such a significant commentator on healthcare, not only in the U.S., but in the whole world. How did you get down that road to this place?
Well, before I answer that, I just want to say how honored I am to be here with you and here at the NIH. This is the center of science, and I just want to say how grateful I am that you were appointed as the NIH director again and said yes to lead our scientific work. It's a crucial time for scientific leadership. And I think my pathway intersects a lot with science. Along the way, I got involved in a range of different kinds of work. I was talking with your postdoctoral fellows earlier today, and I told them that one of the best pieces of advice I ever got was that before age 40, say yes to everything.
And after age 40?
And after age 40, say no to everything. But the idea was that you are experimenting in your life and paying attention to what really gives you energy. And so along the way, I did everything from had a radio show in college to working in a microbiology lab on Epstein-Barr virus in medical school. But among the things that I found myself doing, including that politics and philosophy degree at Oxford, and my Indian immigrant parents were very worried about where all of this was ultimately going to end up. But what I found I loved was problems at the intersection of some of our most significant public issues around how we deliver health care and access to health care for the country, understanding how we really create better outcomes of care, and finding that I was in this unusual space of being able to probe and enjoy probing it through journalism, writing about where are the failures in delivery. One of my first articles for The New Yorker was about why do doctors make mistakes? Mm-hmm. And I was in the middle of my training and trying to understand how do we deal with the fact that I'm a newbie learning on human beings, and how do we have permission for that? And how do we give permission for that? And then going further and saying, how do we manage to reduce the risks, reduce the errors, but still enable learning along the way? And what was surprising to me was that part of the pathway was I got to, a friend of mine started an internet magazine in the mid-90s and asked his friends to write it. Basically started writing what we would call today a blog, but we didn't even have that word back then. This is Netscape Navigator days. Oh, and wow. and that would be a place to probe questions of public importance and write about it. But then on the side, the surgeon in me wasn't happy to just be an observer. I wanted to test the answers to some of these questions, including how we reduce errors, how we address failures of healthcare delivery. And so I've ended up with this odd tripartite career where I do surgery, I run a research center called Ariadne Labs, which is a center for health system innovation, where we'll do experiments at population scale. The last 5 years with the state of South Carolina, learning how do we apply techniques that research has shown and test at large scale whether we can reduce deaths in surgery at a state level, or with the country of Moldova, or reducing deaths in childbirth in North India. So it's been this unusual chance that I think has been what has made it work, is I get to ask odd questions that mostly are the ones that confuse me. Why are healthcare costs so high, and what can we do about it? Why do I hate my computer in healthcare? And why can't it be a tool for actually in making us better in care? And tackling these kinds of questions and then testing them in the real world has been this constant learning cycle.
And how do your surgical colleagues view this particular behavior on your part? Because it certainly separates you from much of what they're doing every day.
Well, so when I applied in surgical training, I didn't even know how it would all come together. I had come out of being in government for a few years and wanted to put together public health, public policy, and surgery. I didn't have any intention that I would combine them. I just wanted to do them together. Mm-hmm. And most of the places that I interviewed at, they'd say, how does this go together? Just you have to decide what you're really going to do, boy. And then at the Brigham and Women's Hospital, the chairman of surgery said, that sounds really interesting. I don't know where that could go, but I have some people I want you to go talk to because they might be thinking the same way you are. And that's how I met my mentor, who happened to come from internal medicine. It just was a place where people could put ideas together and try stuff. Mm-hmm. And that's how it began to evolve.
Well, let me ask you, because we're here at NIH, and maybe one of the big questions we could talk about is this terribly long gap between when research is carried out and demonstrates that there's a better way to do things in terms of prevention or treatment of disease. And then we wait, and we wait, and we wait. And sometimes it's a couple of decades before what we think we're pretty confident about on a research basis actually gets implemented. I know this is something that troubles you, that you've written about a lot. Maybe start off and give us a sense of what you think the solution to that is, because otherwise, here we are producing this incredible volume of useful information, but it's not getting used. And for all of us who have dreams that NIH is going to solve problems, this is a big impediment.
So I think this is one of the probably one of the core opportunities for advancing human health is recognizing what the nature of this problem is. So this will be a little long-winded, but let me try this. There are basically two reasons why we would fail to save lives. One is ignorance, and that we've tried to solve the problems of ignorance, not knowing everything about how the world works and how to control it, by doing research and investigation in the laboratory for breakthroughs in science and innovation. And the last century has given us an enormous volume of those breakthroughs. But the second reason we might fail at anything is what a group of philosophers called ineptitude. I prefer to call lack of execution. And understanding that the ways that we attack the failures to execute are fundamentally flawed because we don't apply science to it the same way we've applied science to breakthroughs. So the problem of follow-through, we attack it by saying, well, if people aren't washing hands, boy, we discovered that 150 years ago, or people aren't taking the discoveries of precision medicine and applying them correctly and rolling them out in the world, then we say, well, we have to increase our training. That's the first thing we do. So now to become a physician, for example, you in surgery, you go through, after 4 years of medical school, you go through another 5 to 8 years of training in surgery, and then you do a fellowship for another 2 to 3 years. You're 40 years old before you even start, right? And that's the solution. And then we find out that you still don't get great results. You get extremely variable results. You're not following through on all the stuff just because we teach you. So then we get mad, and now we impose mandates. There's going to be guidelines and pay-for-performance programs and malpractice regulations and all those things. And they work. They have some modest effects that show some improvements, but they still have enormous gaps in follow-through, and you get that 17-year average time from an NIH discovery to reaching 50% of the population, forget 100% of the population. So the third part is you systematize what the discovery is and how you deliver it. And that requires applying science to the follow-through in what we do. And I would be happy to probe that a little farther. That's the center of the work that I do on the science side, most of all. One example being that we know there is a 250% plus variation in the likelihood in your outcomes from surgery depending on who you go to see and where you go to see.
This is your South Carolina study?
Yeah. So this is looking at surgery in general, that we've known this for a while. One of the approaches that we've taken is to probe, not just to describe the pattern, but to zero in on the positive outliers and try to understand what are they doing differently.
The positive outliers.
The positive outliers, not the negative. Try to understand what the positive outliers are doing. And then turn that into a testable hypothesis, a delivery component. And if I could get a slide, I'll show you, this was the work we wrote about in Checklist Manifesto. If I get the slides up. I'll zip ahead to some of this work here. And this is where what we designed was a checklist based around what those critical components of care really are. Systematizing, I was drawn to checklists because they're the simplest system human beings have designed to deal with the fact that you have two problems. One is the fallibility of our brains, we forget stuff. And then, more importantly, the difficulty of coordinating among groups of people. And in an operating room, you constantly are dealing with new teams. And so what we found was that the high-performing teams that got better results did certain things the same way every time. They made sure that they had communicated in a kind of huddle before the operation to make sure that the known steps to stop the big killers like infection, management of bleeding, unsafe anesthesia, that they did a verbal check about that. And that we found that there also places were running through not a recipe for how to do every operation, but a recipe for how to be prepared. And so making sure that everybody discusses what's the goal of the operation, how long does the surgeon think it'll take, how much blood loss should we be ready for, what equipment do we need, the anesthesiologist reviewing, what's the medical issues of the patient. And so that was step one, is design something could work. We piloted it locally and then took it to 8 cities around the world, deliberately testing this model. So it's saying, can we apply science rather than just yell at people? Test whether this is a viable way of doing it. We test in 8 cities and deliberately picked from the most impoverished in the world, in a rural hospital in Tanzania, in a crushed hospital in urban Delhi, to University of Washington, Seattle, which was in the top 10% of hospitals for their outcomes around our surgical monitoring data. And in every hospital, there was a reduction in complications. We published the results in the New England Journal in 2009. The average reduction in deaths was in complications was 36%. The average reduction in deaths was 47%. So there was no drug or device that was anything like this. So now, fine, we did it with 10,000 patients. South Carolina was the test of, can you roll it out at large scale, and what does it take now to systematize overcoming surgeon resistance? And that's the curve we've been mapping now, which is how much implementation effort is required to achieve the mortality reductions. We saw that in Canada, Ottawa mandated it just by law with no implementation system or supports, 0% increase in mortality. We just completed in South Carolina a voluntary approach that 40% of the population's hospitals completed a 19-week stepwise program and successfully lowered their death rate 22% compared to the control group. So, I write about the human side of it, but it's also constantly learning from the testing side. And I think the thing that we're learning to do, as you and I have talked about, it's putting your discoveries from precision medicine together with precision delivery and believing we can apply science just as fruitfully to the way your knowledge moves out in the world as we did to the discovery of that knowledge. And in fact, it will save as many lives and arguably more than our next discoveries, given how much we've already discovered that's not getting to people in the first place.
So what role does transparency of outcomes play in that? I hear what you're saying. You want to reward and encourage the people who are positive outliers, but wouldn't it be good for patients and the rest of us to know the whole spectrum of what's actually happening as far as outcomes? I know you've been doing some of that in South Carolina, and I know you also are getting strong messages from the providers that they don't want their outcomes to be visualized by anybody except you, maybe under a strict anonymization kind of circumstance. But seriously here, any other business would expect that they are going to be scrutinized in terms of what they're actually delivering, and yet medical care hasn't been subjected to that same level of quantitative analysis. How do we use that, not in a punitive way, but as another sort of motivating tool to try to shorten that 17-year gap?
So it's absolutely crucial. You cannot do science and learn without the data, right? And if you cannot see what outliers, where the outliers are and what they look like, and then gather that information, and then share the knowledge so that people can learn from it, you get these long and then incomplete learning loops. Yeah. One of the striking things is we do have fields that have been transparent for a long time. We have had the public information about the infant mortality rate and the maternal mortality rate of American hospitals since a White House report in the 1920s. And that has been crucial to the success of our delivery of knowledge into obstetrics. We went from it being the #1 killer for women in the country, and birth being at levels 50 times higher than what we have now, to making it one of the rarest causes of death in women's lives. And a core reason why has been that ability to have that kind of level of transparency. So it's one of the crucial tools that we need for investigation. I think one of the things to understand is it's a tool that is the property. You know, what's interesting is even in the 1920s, people understood that it was a property of the health system. The data that was transparent was about the system. And what we seem to want to attribute is that it's the specific surgeon or the physician involved. We have a bunch of studies underway, for example, tackling a different problem at the moment among our portfolio. There are 11,000 people who are born on any given day in the United States. 11,000 women will come into a hospital for delivery. 1/3 of them will have a C-section. 10% of them of the children will go to the intensive care unit. And we will spend 0.6% of GDP to make that happen today. Could we do better than that? Part of the reason we know is because the variation in the likelihood that woman will have a C-section is from 7% to 70%, depending on what hospital you go to. If you risk adjust, that 10-fold difference becomes even bigger, which means that it's a system property. Recently, our team had done a study in which you want to blame the variation on the obstetrician. Within a hospital, there is a 5-fold variation depending on which nurse you get. We proved that just in the last couple of weeks. It's a system property, and so the transparency you want is about the organization, because the knowledge that you guys have created over the last century so you have helped identify that there are 60,000 different diagnoses, 60,000 ways the human body can fail. In the last half-century, we've devised 4,000 medical and surgical procedures, 6,000 drugs that we can deploy that reduce suffering and reduce complications and improve your outcomes, and in many cases can cure. It has exceeded, that volume of knowledge and skill has exceeded the ability of any one clinician to know how to manage it. We are all part of groups of people delivering care. We don't know how to deliver as groups successfully. You need data to see how the group is doing, and then to intervene in that system, just like you'd intervene in a cellular system, to see how you enable the pathways that are the right ones that get you the best possible result.
So you and I had the fun this morning, just as you had arrived, to descend on a group that's meeting up on Executive Boulevard, which is the consortium that is launching the All of Us study, this unprecedented million-strong longitudinal cohort of Americans to see what we can learn about health and illness and how they happen and how to prevent illness. And one of the many questions that came up, of course, was what would you say would be most useful for that program with this potential of collecting a lot of data on a very diverse population? What kind of information would be most helpful in this area we're just talking about? Again, moving from precision medicine to precision delivery. That, of course, is just one of many such large-scale projects, although it's the largest that NIH is undertaking. So what could NIH do here to make that transition from knowing something to delivering it happen?
So I think this is what's so exciting about where we are now. I got to lecture here 8 years ago about this idea of understanding and applying science to the system, and it wasn't a natural fit yet for the kind of science people do here. But now you're in a new place where precision medicine meets precision delivery. I think in the All of Us research initiative, 1 million people who would agree to having their data captured. And that data is their biologic data, their genomics, their laboratory tests, what we know about their biologic condition, but then also potentially wearables, so what are their behaviors over time, how does their sleep, their nutrition, other things affect them, but then also adding into it the information about their community and their health system. What did the health system do to them? What kinds of results came out of that? The powerful thing is when you have a setting where you begin to see those interconnections. Someone with a wearable after they've been receiving care for primary care or specialty care, and you begin to see what is their pathway, how much physical function, cognitive function, emotional function, what is the level of well-being that they're getting from this care, how does it fluctuate and change over time, what's the relationship between what we know about their biologic condition, what the system is doing. And invariably what we find is that, and I suspect will be found here, is that where the system is most organized and behaves like a system rather than a kind of uncoordinated conglomeration of components, that the care ends up being better, it has more intention behind it, there's more learning that happens along the way, and it often is typically lower cost along the way as well. And we still are, I think it'll be crucial to understand where does that kind of platform provides the opportunity to be able to connect all of those dots, to have the electronic health records, the wearable reality of the experience of the patients, and their biologic information. That's truly precision medicine and delivery.
And where did we go wrong with electronic health records, which were supposed to be such a boon to taking care of patients and doing research? And now most of the time we end up sitting around complaining about how difficult it is to do either one of those things. You must have some views on this as an observer of the American healthcare system. How do we fix this problem of interoperability failure, not to mention just user friendliness? Is it just because these were all developed for billing purposes and everything else was secondary? How do we fix this?
You put your finger on it. If you ask, what did we put the system in to do? What customer was it serving? And if I've gone to meet with the IT companies, I say, when you have to sell a healthcare system to an IT system to a healthcare, to a hospital or to a clinic or whatever, who do you have to go see and convince? The chief financial officer. That is their number one customer. And what they want to make sure you're doing is that you've got a really high quality billing system. So it is literally maybe 3 or 4 keystrokes at most. It is a 5-second procedure for me to put a bill through. But for me to input the allergies of a patient, we got a 5-minute video on how all of us were inputting the allergies wrong. So we have to learn on the video about you got to click to this screen and click to that screen. Do not enter in the following way. So it is not optimized to make it easier to deliver care. And the core problem is the amount of knowledge we're trying to integrate and then deliver to the patient and the number of things that we're coordinating. The system, they do make it, there are ways in which, look, I do not want to go back. One of my colleagues, by having prescription order entry move onto computers, it's demonstrably cut the rate of errors, of medication errors, by greater than 95%. But it is not optimized to make it easier for me to have a more human, more effective, and a more reliable interaction with other people along the way. And so, we're in the C prompt days. This is the MS-DOS phase of the computer system, and the cloud computing based Apple-like user-friendly option that makes it possible for the doctor and the nurse and the clinician and all of the other patient and all of the other clinicians involved do a better job for you. That opportunity is wide open, and somebody will grab and dislodge where we are now.
Can we talk about opioids? Because this is certainly something of great concern across this nation, and to us at NIH right now engaged in a big push to try to see what we could do scientifically to come up with some better treatments for people who are addicted, for better treatments for overdose, and very explicitly to identify potent but non-addictive painkillers that could substitute for the opioids that killed 33,000 people in 2015. Many people see this as actually a crisis that the medical profession has to take some ownership of, with the recommendations back in the late 90s that no patient should really be allowed to have pain if you could treat it, and that things like OxyContin in a delayed release form would not be addictive, and so we should be writing those prescriptions, and we have been doing so. When I had my own surgery a year and a half ago, I went home with a bottle of 30 days of opioids, which was utterly unnecessary, but that was pretty typical and may still be so. So here's another case of a healthcare system that has made a pretty terrible mistake, but it has persisted much longer than it should. And maybe you could comment on what you might see there as the best way to try to tackle this, to end what is otherwise an escalating and so far showing no signs of improvement epidemic in this country.
Well, so partly I think it's to recognize that we will not get very far if we say, well, we need to be now training all of the medical students and residents in the right way to do things, and then yelling at them or putting in mandates when clinicians don't follow through on doing those things. It's figuring out how to systematize making the key practices matter. And the amount of funding that we've put into studying and understanding what those key practices are has been minuscule. But nonetheless, we've learned enough to recognize, I'll give a core example. We know now that it's between, depending on the studies, 6 and 10% of patients who are put on a short course of opioids for surgery will still be on opioids a year later. And we did not know that the rate at which people could become addicted is that high. We're doing 50 million operations a year out for 300 million people in the country. So this is that's a devastating figure to begin with. Second of all, we did not know how few opioids people needed to have good pain control. So in a recent issue of the Annals of Surgery, there was a set of studies that all done without real funding, so they were done kind of on a shoestring, and the quality was limited and somewhat anecdotal, but they demonstrated that you take mastectomy patients, it turned out the average person they had less than 10 pills that they used, that 80% could be covered with a prescription for just 15 pills, and we were prescribing on average many times that. Knowing that data then has led people to shrink a number of pills they're using, but it was only a few of the 2,500 operations that had been studied. So one thing is just map the real curves. How much are people actually using? Second was recognizing, and I wrote an editorial on this for this paper, saying that the reason why people are giving these long prescriptions are that the requirements are that if you ran out of pills, you had to get a paper prescription and had to go trotting into the doctor, but you're calling at 8 o'clock at night. So now what's supposed to happen? So we chronically because we don't want to leave you in pain.
And the doctors don't want to be bothered too much either, let's be true and
right.
fair about
That's right,
that.
Don't want to be. New York State implemented an electronic prescribing approach that they tested at demonstration level and then have made statewide. And that the whole state has successfully switched over to physicians ordering narcotics electronically, which means that they can enter the order, that you can track when there are illegal manufactured prescriptions. You can trace every sort of prescriptions allowed, much more control, reduction of diversion, and when a patient, if you prescribed a little too few, the patient could call you up and you could order 5 more and it would be there for them. So there are systematic measures that can be taken. I think there's an incredible role for NIH in being able to define those patterns and then support the innovators who are making those kinds of systems come into place.
In an article you wrote for The New Yorker called Big Med, you had this long description, which was really quite entertaining, and I hadn't expected in an essay that you were writing, about how the Cheesecake Factory does its work in its kitchen in order to meet
Not
the
that I
needs.
recommend it for their nutrition, but I do think they're really impressive.
They were very, very much well described by you as being incredibly efficient and focused on quality. And you kind of then contrasted that with medicine, which has a rather different view of these things. In that article, you wrote about, and I had not heard about it till I read this, a circumstance where, at least in some communities, there is a central ICU monitoring facility that's not actually in an ICU, but it is watching the patients in ICUs in a network, trying to pick up on the fact that something is about to go wrong that the nurses and the docs in that actual physical ICU might not have noticed. How broadly is that kind of technology catching on? What's the follow-up there? Is this what we're going to start to see more and more of, where you have the opportunity to do that kind of monitoring at a distance and prevent errors?
I think it's one it has increased and moved along in the world, especially when we have discovered, so this is a nice example. We have discovered that having a dedicated ICU intensivist-trained person in a critical care unit leads to substantially better outcomes for people who end up needing critical care. But community hospitals, there aren't enough intensivists to go around, and community hospitals don't have the volume to be able to pay for that capability. So then the choices became that you couldn't get critical care without needing to go to swamped, centralized places. And so these kinds of systems that allowed for, a hub where you'd have an intensivist taking, being the person who could consult with the nurses, and then general physicians being available to back them up, allowed care to happen in multiple sites, and then could demonstrate better outcomes. And it's part of this important way in which we, a fee-for-service system rewarded innovation that kept moving you to higher and higher levels of cost and intensity. And now we're starting to see innovation about how to push that capability out further and further into communities by taking advantage of technology. And I think it's just one example. The newest area has been in doing actual hospital-at-home care. So taking people who have acute illnesses, being able to have monitoring at a distance. And so, the most common example is pneumonia, now being cared for in hospital settings at home. Our hospital is experimenting with this and carrying out a hospital-at-home function. Wow. It's being done in New York City and other places around, and it is about doing the same thing and coupling innovative technology, the ability to recognize danger signs at a distance and do it accurately, while deploying human capability to where it needs to go, either to pull them into the higher level of care or push people out to where they are, and do it in ways that allow us to not have to employ 20% of the country. We shouldn't have to take care of, shouldn't require 0.6% of GDP just to deliver our babies, and do it with incredible rates of overuse of surgery and unnecessary intensive care applied.
Indeed. I'm going to start taking a question or two from Twitter and Facebook. And one of them is about your documentary and the book you wrote about being mortal, a book that I think many of us who had the chance to read it were quite moved by, because you spoke quite personally about experiences in your own family with individuals who reached the end of their life and were either allowed a dignified exit or not so much. And unfortunately, in this country, oftentimes it's not so much. The documentary, I think, also was seen by many people. We here at NIH do research on end of life, trying to identify what are the optimal strategies. Our Nursing Institute in particular has a big portfolio there. Do you see some recognition happening that maybe the way we've been doing things, that we should spend vast sums of money on those last few days of somebody's life, and oftentimes put them in a position that they really didn't want to be? Are we getting over that idea that everything has to be done for everybody, no matter how desperate the situation?
Well, so I think there's really important progress there, and I'll try to highlight three things. One is that when I put the book out in 2014, this was considered death panel work. And the belief was that even to just have discussions about what better care would be for people as they come to the end of their life was was a forbidden thing, was regarded as a kind of betrayal of basic values in care. And what I wanted to understand was, well, then how can we do better? Because what the world perceived, and what I perceived as a surgeon, was that these discussions were about, do you want to fight or do you want to give up? And what I came to understand is that it really is a question about, okay, you want to fight. What do you want to fight for? Do you want to fight for your best possible day today, or to sacrifice your day today for the sake of possible time later while we treat you with different kinds of ways? So the second part of it was that learned from the process of the journalistic investigation of the book that there is in fact a ton of research that comes out of the NIH, among others, that has demonstrated some really basic kind of things. That people, including the very seriously ill and the frail, have goals in their life besides just survival. They have goals for the quality of life and their purpose and what a full life looks like. And they want our medical capabilities to enable those core goals. The most reliable way to find out what people's goals are is to ask them. But we don't ask. We ask less than a third of the time. And when you don't ask, then it's not a surprise that the care we deliver is out of alignment with what matters most to people, and then you get suffering. And so what has now followed through is that people are recognizing that they actually need to take control of their care by voicing and demanding that clinicians know what their goals for life are, for their care are, besides just survival, what their goals are for the quality of life. And we have what's not much known about is the third part of what I'd like to say, which is that behind the book, we've been carrying out a set of research trials. And that set of research trials are a couple of things, if I could flash up a couple slides. So the research trials have been where we've been surveying people across Massachusetts to start with.
Put the slides back up.
Yeah, if we can have the slides. And one of the things that we are demonstrating from this work is that, I'm going to skip these slides. I put a bunch of slides in a deck because I thought different questions might come up, and so there they are. And so this one says that, in fact, just having these conversations is incredibly powerful. When someone came to the end of life, we're talking to family members about experiences they've had with a loved one who died. And this was a statewide survey. It turns out more than about a third of people in the state have someone who died in the last year that they watched go through the process. And the quality of care that they described, the extent to that was only 21% rated the care as excellent or very good when their family member had not had a chance to talk to the team about their wishes for the end of life. When they did get a chance to talk about that, 84% had a excellent or very good care. We distilled into a kind of checklist what the conversation from highly skilled palliative care and geriatric physicians looks like. And it's a conversation that you could bring to non-palliative care skilled clinicians, and that is to ask people questions that identify their goals that they want for their care, like what's your understanding of where you are with your illness? What are you willing to go through and not willing to go through? What's the minimum quality of life you would find acceptable? And then matching care to that along the way. And then we've been carrying out behind the book an RCT involving the entire Dana-Farber Cancer Institute. 80% of the clinicians agreed to participate in the trial. Half of them we put through training in this program, half of them didn't. And we coupled it with a system for identifying the patients at highest risk of dying and sending reminders when they had not gotten these conversations. So what we found was the conversations led to more earlier and better conversations, with 92% having these conversations. At baseline, less than a third had these conversations. Just the existence of this program pushed the control group up to 70%. They were earlier, so they were happening at 5 months instead of just a few weeks before the end of life. And they were better in that they were not just a discussion about code status. They were about people's larger goals. And then among other findings, I'll just put one last data slide here, is that we found that anxiety levels, and there's a similar one for depression, so far, preliminary data, has been a 50% reduction for people facing serious life-limiting illness, 50% reduction in their level of moderate to severe anxiety and depression without hurting their quantity of life along the way at all. So I think what we're seeing is we're now developing the systems for how to deploy it, and we have large systems across the country that are now driving this into practice and learning how to drive it into practice. So this is, in just 3 years, from 2014, where no health system wanted to publicly say our goal was to give you cutting-edge care for the end of your life. Now, I have entire health systems. The Baylor Scott & White is pioneering with us, bringing this across a system that has more patients than the whole state of Virginia. And the way they've put it is, we want to make sure that you know you will get cutting-edge care for the quality of your life and for the quantity of your life. And that can be done.
That's very encouraging. Bravo. There's a question here from Facebook. I know, Atul, that you, through Ariadne Labs, not only do research in the United States, but also in other parts of the world. The question is, how do we as a country with many healthcare resources work to bring our discoveries and technologies to regions that have a less developed healthcare infrastructure? What obstacles and opportunities do you believe currently exist? And what can we do about it?
Well, so, you know, we do work trying to treat populations as a big experiment. So I talked about South Carolina, we talked about here using the whole Dana-Farber Cancer Institute, but then we've also created these partnerships in other parts of the world. And I actually think that my reason for doing it is because I think there are lessons that we find there that we bring here.
Oh, yeah.
It's totally bidirectional. So, for example, we're doing work in India, in North India, around, there are 7 big killers known at birth, and this is addressing undertreatment in a very low-income population where the death rate at birth is 5%. 1 in 20 babies die at or around the time of birth. And there are 7 big killers for moms and babies, and those are infection of the mom, infection of the baby, obstruction for the mom, labor obstruction, bleeding for the mom, asphyxia for the baby, prematurity, and yeah, I got them. Look at that, 7. So, and each of those we have known practices that have been recognized in the Western world initially that save lives and can reduce those deaths by over 90%, really by greater than 95%. And so we began rolling out a combination of a checklist, data feedback, and on-site coaching visits that have made marked improvements in those results. What's interesting to me is that many of those same tools that have then come back. So the United States has the worst maternal death rate of any developed country, which is unconscionable. California, a coalition there, has been taking the basic checklist items for 2 of those big killers, which are hypertensive disease in women and hemorrhage. So eclampsia. Measure the blood pressure in every woman, really follow a basic protocol that if the blood pressure has gone up by a certain level or is over 140 over 90, institute critical next steps, including magnesium and hypertension control. And we just weren't doing it. They successfully carried it through only for about a third of the hospitals in the state, and they've already cut the entire state's death rate by half.
Wow.
So it goes both ways. It goes both ways. And, you know, by the way, then why isn't the rest of the country now doing this, let alone the rest of California?
Yeah.
That's the next set of things that they're working on that we were trying to help with. But I think this is, there are tremendous opportunities when you understand that working with populations to test these approaches and understand why they're not able to do it, and then make it easier for all clinicians to handle this complexity. That is the task. We're trying to deploy this capability town by town to everybody alive. I think it's the most ambitious thing human beings have ever attempted. Harder than going to the moon, harder than anything we've ever done. And so it's not a surprise we're failing. What is a surprise is we're not applying science to it, and we can, and it's producing tremendous dividends when we do.
You know, in your most recent New Yorker piece, Tell Me Where It Hurts, you paid particular attention to the way in which we seem by our healthcare reimbursement system to attach value to the heroic steps, the emergencies that are suddenly captured by an experienced physician and turned into a successful outcome. And we pay much less attention to the incremental care, which in the long run is what most people will have their lifespan and health span benefited by. I think I told you my own story about my daughter, who's a physician in North Carolina, is board-certified internist and nephrologist, but decided that her goal would be to treat people with hypertension, for whom all other measures have failed, and which means, therefore, a very intense effort, doing some pharmacology, a lot of personal counseling, and something you can't do in 7 minutes per patient. And her compensation benefits as a result of that is a salary approximately of $50,000 a year. And yet, surgeons and other interventionists, we won't name too many specialists or I'll offend everybody watching, do vastly better than that in terms of how compensation is played out. All of the things you're talking about seem to be counter to the way in which our current system
provides rewards to the practitioners. And if we're really serious about taking precision medicine into precision delivery, we may need a lot more kids, or now not so much kids like my daughter, and maybe fewer of the intensive specialty-oriented, procedure-driven enterprise managers. So how are we going to change that part of our system in the right direction?
Well, the first thing is that I think we have to understand how this is, in fact, a victory of science. If you were in the 1950s, it was only heroics that had any real value you could apply. You know, it was the discovery of ways that you could do surgery, or you could apply antibiotics once someone had developed a pneumonia, or follow through on handling disease once it had appeared in florid form. We didn't know high blood pressure was the killer it was, and we didn't know how to control it. We didn't know about cholesterol. We didn't know about a lot of different things. And the fast forward to today, our ability to know what matters has been because we have collected data and tracked over time, and then recognized these patterns that you can't see except how it unfolds over 10 years, 20 years, those kinds of things. And now we've discovered that the biggest killer in the country is high blood pressure. We have a third of adults have high blood pressure, only 40% have adequate control, and we know ways to drive that much higher. And when we have delivered those ways, Minnesota carried out an approach to try to get that number up, and they got up to over 70% of the state where you would recognize people with blood pressure, and then you actually provided the care. And they have flipped from the cardiovascular disease being the number one killer in the state to the number two killer, and now you have many states where that's starting to happen. So we're flipping to a place where the lines are crossing. The value of the heroes, the interventional heroic care, is the value of it is sort of flattening, and the value of the incrementalists, those who can detect disease in advance and then work with you to address it over time using data and then tracking you over long periods of time, is rising and rising and rising, and it's only increasing as we discover genomics, which allows us to predict and manage disease, recognize patterns out of the All of Us research program that become a way that you navigate through life with your data, helping you stay on paths that keep you healthy, productive, and without all of these interventions. So we have to switch from fee-for-service medicine, which has been based on reward for the heroic care, to really almost panel-based care, based on being able to be your care partner through long periods of time and work more and more effectively. So yes, we're in a place right now. The easy way to recognize what fields are those that are going to be most important is look at what the lowest paid fields are. You know, geriatrics, palliative care, things like your daughter does, primary care, rheumatology, infectious disease. All of these fields, especially the chronic infectious disease like HIV, AIDS management is a classic example where enormous value from following people steadily over time and coupling data.
And all the surgeons who are watching this are saying to themselves, he's a traitor. So I see a question from Twitter. I imagine it might even have been sent by somebody who's in the room. It says there's a lot of young scientists in the room, and probably medical students and physicians as well, still in training. Any advice for them?
Yes. I think the cool thing about where we are is we're in a transition around our science and our policies. And that is that the power of the last century in science has come from reductionism, focusing on a single area and really understanding a component of what happens very powerfully, identifying the gene, the neuron, the molecule, the drug, the device, the specialized operation. What we are now recognizing is it's the interconnection among these, though, that you need to understand. So it's how the genes connect to create a disease and interact with the environment. It's how the neurons connect to produce consciousness or dementia, and how the drugs and the devices and the specialists fit together successfully to produce better outcomes. And so the future, I think we're switching from what one of my colleagues called the century of the molecule to the century of the system. And it's becoming the scientist of the interconnections, whether it's at the molecular level, at the physiologic level or at the population level that is going to be where the biggest insights and the biggest gains in health and understanding are going to come from. That's where I would be spending my time.
So you're an optimist. Despite all the diagnoses you have placed upon our medical care system and all the things that you've helped us see are not right, you have a sense that we're going to figure this stuff out?
Absolutely, and I think that's why my colleagues have not shot me. I started writing as a resident, and I didn't get fired from the Brigham and Harvard Medical School and got hired. And the reason why is I was doing it from a place of, my fundamental interest started with, how do I become good at what I'm doing? And it became, how do we become good at what we're doing? And understanding that along the way. And applying our analytic capabilities and our innovation to it, it is producing tremendous dividends. We got to reduce deaths in surgery 47%, and at a state level 22%. Like, how can you not be excited by that kind of stuff? This is so great.
Well, Atul, this has been a wonderful opportunity to learn from you. We are the National Institutes of Health, but we also think of ourselves as the National Institutes of Hope. And we have hope, as you have just very wonderfully articulated, that applying the tools of science all across the board, from the most basic through the translational to the clinical to the systems, is the way in which that hope can be realized. It's one thing to have the hope, it's another to make sure that it actually turns into real change. As a change agent of a particularly effective sort, we're grateful to you for your voice, for your ability to inspire, your ability to help us think outside of our narrow zones, because you are a big thinker. And we appreciate you bringing your big thinking here to NIH this afternoon. Please join me in thanking Dr. Atul Gawande.